Hello, I am Danielle Willis, and I teach in the School of Social Work here at Colorado State University. And today I'm going to be talking with y'all about trauma-informed care. I will be doing this for the Inclusive Health Collaboration for the Larimer County Behavioral Health Grant. I use she and her pronouns. As we talk about trauma-informed care, we need to understand that that means clear is kind. We're going to give as much information when working with populations in whatever setting we're working in to be intentionally thoughtful and clear with anyone walking in our doors of our facilities, our agencies, our clinics, to be ensure they know the process, they know what to expect, and we're all on the same page. A couple disclaimers for our conversation today. Those who we will see have experienced trauma. This is a big disclaimer for this whole conversation, that even bringing up some of this can bring up things for us as providers, as social workers, as interdisciplinary veterinarians from all different angles. But we need to understand that we've all experienced trauma in some ways, and especially those who have had to access our systems, marginalized identities, BIPOC communities, insecurely housed, homeless individuals have experienced trauma based even in our systems. And we need to understand that we are allowed to get support too as providers, and we're allowed to be clear and trauma informed to provide services. There's layers for every population we serve, and that intersectionality that Kimberly Crenshaw always talks about from different identities and how that affects our system shows up in this work and with trauma-informed care. So for our talk today, I'm going to use a trauma-informed technique, and we're going to use a roadmap because that's clear and kind. So what we're going to talk about for the next about 20 minutes is what trauma-informed care is, harms from uninformed systems that all of us have experienced and those who have to use our systems have fully experienced, how to lead your interactions, how to lead your interactions and work with trauma-informed care, how to support your systems to improve its trauma-informed care processes and environments, how can we be creative with this, curious with this work, and resilient with this work, and the changes you will see, and you're going to set your own goals to make. So I appreciate y'all taking the time to listen to this video, as I know everyone is extremely busy. But what trauma-informed care is it's a strength-based service delivery approach that's grounded in the understanding of responsiveness to the impacts of trauma, right? It emphasizes our physical environment, our psychological environment, and emotional safety for those that we serve, from guests to clients, for both the providers, the survivors, the supporters, and again, those clients. And it's based in empowerment. It also involves awareness and anticipating and avoiding institutional processes, right? And individual practice that likely will re-traumatize. And that's our big takeaway here for our IHC clinic and overall in any agency that y'all are at, is our number one job is not to re-traumatize those who we're trying to serve and support. So we're going to understand historic traumas that could have happened, right? We're going to uphold the importance of participation, meaning our clients get to be involved and say what's working and what's not. And much of the talk today will be out of the SAMHSA's tips around trauma-informed care. And I'll have references for y'all at the end. Good resources. I love the 4 R's of explaining trauma-informed care because it's just clear. And that's, again, what we want with trauma-informed. So we're going to be resistant to re-traumatizing. So we're going to understand our organizational practices may compound traumas unintentionally. So we're going to be thoughtful that paperwork needs to be less overwhelming, less intense at certain accessible levels for reading, etc. We're going to recognize that people within these organizations are able to recognize the signs and symptoms of trauma. We're going to realize that all people at all levels have basic realization about trauma, right? We're going to respond to programs and organizations and communities to be intentional to encourage a trauma-informed approach. I love the 5 key principles noted here on the screen, but safety, top of the list, trust with our relationship founded, like we talked about in the ACEs video that y'all watched before this, with choices that we're going to provide, collaboration that we must insist upon, and empowerment. Those are the top of the list to be strength-based, trauma-informed. Again, we're going to walk alongside someone. Our job is to, again, follow the community's needs, follow our individual guests' needs, not lead those. Ask about them, listen, change our systems to respond more effectively and intentionally. To build that out a little bit more, these were mentioned on the 5. This is another look at it with 6 core principles, and I like the language, so I added it. From safety, like we talked about, trustworthiness, transparency, peer support, and mutual self-help. This is a big deal. We know community-led interventions are where it's at for effectiveness. We're going to keep building those programs and getting our participants and clients on our boards to change things within our systems. Collaboration and mutuality, we're going to work together. We're going to have empowerment and voice and choice. We're going to understand cultural pieces, right? We're going to be responsive, culturally humble, understand our limitations, mind you, of our identities. We're going to understand the historical pieces and gender identity awareness, such as the beginning, me introducing my pronouns to start the conversation. So harm from uninformed systems is a big issue and a big piece of why trauma-informed care was created. So we understand traumatization occurs when patients, right, our clients or guests experience something that makes them feel as though they were undergoing another trauma, those triggers that we talk about. And we know from Danielle Siegel, I talked about this a little bit in the ACEs video, but trauma in the brain, what happens when we get that re-traumatizing from a system? Sometimes our lid is flipped, that hand model we'll see here, and that means our frontal lobe, our reasoning lobe, goes offline. This is when we can't think straight, we're emotional, really reasoning, we're saying, why don't you listen to me? You're not understanding. We've all seen that at different front desk systems because of that re-traumatizing. So us being trauma-informed, we're going to be intentional at how do systems cause re-traumatization. We're going to have awareness and then a response. So our awareness is being unaware, what we're building is being unaware of the patient's traumatic histories significantly affect their lives. We understand that those who walk through our door, say at the Murphy Center, at the IHC clinic, getting their pet seen, also have experienced insecure housing, for example, or system struggles where they have to run around town to get any access to care. We need to understand the challenging or disconnecting reports of abuse. So lots of times things go unheard, and it's our job to listen. We need to understand that isolation can happen. And if you've had to be inpatient or in medical settings, they can be traumatizing at times. We can understand the experiential exercises that humiliate individuals, like asking too much, right? Endorsing a confrontational approach. These are not effective. These are traumatizing systems, right? Allowing for abusive behavior towards someone's client. Some systems have done this over the years, and we need to be aware of that. Labeling behaviors or feeling as pathology. Yeah, we're pathologizing behaviors over and over again when it's always like we said in the ACEs video, what do you expect? These systems have been harmful. Failing to provide adequate security and safety. Limiting participation of the patient, right? And the treatment decisions. How do systems cause re-traumatization? Minimalizing, right? Decredit, ignoring, right? Disrupting provider-patient relationship based on schedules or canceling. We know that can be really traumatizing. Inconsistency of the rules or enforcing those rules or chaos with that. Imposing policies without explaining it and no exceptions, not seeing the human behind whatever's going on. Enforcing new restrictions without program, without communication. Limiting access to services, accepting agencies' dysfunction, like allowing for it, including lack of consistency and competent leadership. We know changes happen and systems aren't perfect, and we can do a lot better. So our jobs, now that we set in the hard part, the realities that systems have been broken for years, is that we can do something about it every single day, each of us individually, and then within our organizations and the settings that we serve in. So we're going to not re-traumatize is the top of the list for us. We're going to see the environment through the patient, client, guest point of view. We're going to guide the client through the experience. like the roadmap we talked about. What do you expect? How long is this going to take? Where do I go first? Who do I talk to? Who are the people I want to work with? Have some water, have a seat. Have you eaten today? We're going to guide through the experiences to be effective. And safety is of the utmost top of the list for our providers, us, right? And for our clients. And we can do both. I want to stop and pause and have y'all ask yourself and your team, what are the ways we can improve our system, right? To ensure our program is not re-traumatizing. Is it paperwork? Is it the waiting room? Is it space, how we have things set up? Is it expectations, policies? Pause and think for a minute. How to lead your interactions and work with trauma-informed care. So this is kind of the next phase of our conversation. Is that in order to begin this conversation, we have to check ourselves. We have to check our own stigma, and we have to reduce that and stand against it. We're not going to have opinions about people's circumstances and situations, substance use or homelessness, because we don't know what it's been like to walk in those shoes. We don't know the intersectionality of racism, classism that has gone on in people's lives. So we're going to take a step back, check our own implicit bias, and move to the next phase, which is leaning into empathy. I've added a link in here for you all to watch. I won't share it now, but understanding the difference between empathy and sympathy. You can look this up at the Brene Brown clip. It's phenomenal, or click on below. Understanding that empathy is to sit with someone and truly listen. Sympathy is to kind of look at it from a distance, say that must be tough, or at least it's not like this, and judge from afar. We are going to sit in it and tap into those deep-rooted places in ourselves that understands harm and hurt that we've had in our lives and say, wow, I can't even imagine what that might be like. The big picture is we're going to understand the opposite of addiction is connection. I love that quote. And I know the word addiction seems limiting, but it's really the opposite of that judgment, opposite of that stigma is truly connection. That we must see each other in our holistic selves to be thoughtful and walk alongside someone for their care. Relationships matter, right? Our role in trauma-informed care is that relationship. So Johann Hari, who had that quote about the opposite of addictions is connection, also has another book that talks about protective factors for healthcare, right? Are the roots rooted in connection? We understand that we can rebuild and become resilient, mental health, substance use, veterinarians, med students, social workers, anyone. And we can be that if we find community. So we need to show these videos, talk with your instructors, talk with your professors, talk with your coworkers, find a community so you can be a helpful provider, right? Whatever your role is as. We're going to reduce our time in isolation. Again, work with our groups, provide supervision, talk to each other. We're going to find meaning in our work, right? Like everything we do with the collaboratives is meaningful. We're going to understand connection to your values and find what guides you. So understanding what's the most important. For me as a social worker, I identify with the NASW Code of Ethics, right? And that meaning and values means I truly believe in self-determination. I wholeheartedly believe people know what's best for them. That's my intentionality. And I'm going to lean outside of myself and understand that it's not about me. Check it every day. This frustration coming in at the door, maybe from a client who has been pushed around to different services all day, is not about me. And I'm going to seek support. I'm going to talk to my coworkers. I'm going to talk to my supervisor. I'm not going to function in isolation so I can be effective as a trauma-informed provider every day. So 5 ways to lead with trauma-informed care is to normalize that trauma exists. I've already said this, so I do think it is a bit repetitive, but it is intentional in that. I'm going to describe the commitment to physical safety, to my agency, to myself, right? I'm going to describe the commitment to psychological safety, to my agency, to myself, to my clients, top of the list. We're going to keep this place safe, and this is why we're doing this. We're not just saying arbitrary policies. I'm going to respect boundaries and have undefined leader or unified leadership. That'd be best, right? I'm going to respect that. We're going to hold boundaries. That means we're having trauma-informed care. I'm going to offer and require accountability over and over again for myself, for those I serve, for our leadership and our agency. Okay, like we can talk all this all the time, but we actually work in systems that have rules and expectations. And we have services we have to provide, like veterinarians, a lot of things we have to get done. So for us to be successful in our jobs long-term with the weight and the pressure of the expectations, we need to remember the resiliency model. So this model talks about optimism is key for us to be successful in trauma-informed care. We need to see the good, we need to see the human, and we're having hard days and we're feeling burnt out and we're struggling to see that. We need to be talking with our coworkers about it. We need to collaborate with each other, right? With our guests, with our clients, with our service providers, with our leadership. And then we need to have mastery. We need to know what the policies are so we can tell our guests and clients. We need to know the expectation of our job so then we can do it. That's what's so hard about starting new roles and services is we don't always know for a long time. So the 3 pillars of success to be resilient in our fields are optimism. So we're going to see the good. We're going to find it. If we're losing it, we're talking about it. We're going to collaborate. We're going to work together to make sure we're all on the same page with our clients. And then we're going to have mastery. We're going to know the expectations of our agencies, our policies, our roles, what's expected. With resilience, we're going to be mindful that it's not a simple rate and gauge. It's not linear. It's a process over time. And the road here is going right down. That's not realistic, right? There's curves in the road. There are things that come up. We'll have to take a step back and revisit policies, for example. So with that in mind, prevention of ACEs, we know those protective factors. To be informed, we must lean into prevention. I love this slide, so I had to add it. We understand that there's strengths, right, in family approaches. There's strengths in this trauma-informed approach. We are going to, in our agencies, promote social norms, right, that are protect against violence, right? We're going to ensure strong start for children. We're going to support those early childhood programs, which I know is not our role with the IHC, but it is our role in our communities, right? We're going to teach skills like social emotional learning, right? We can do that in clinic. We can talk through those pieces in a kind, gentle way. We're going to connect and understand everyone needs a community. And if we get to be the community, what a privilege it is for us in clinic. We know the key is simple trauma-informed reminder. Have a 90-second positive experience, Bruce Perry talks about. So meaning you're meeting with a client for 90 seconds and you have a positive experience, you're smiling, you're connecting, you're asking about their life. That's what you need. That is trauma-informed care, and that is how we can successfully build relationships and rapport with those clients and guests we're serving. So in order to do this, some days the days get long. So sometimes we need to take a step back and tap into our senses, right? We can do the 5 sense activity, which I include on the reference. But that means if someone's overwhelmed, we can co-regulate with them. So let's look outside, step into the breeze, feel that breeze. We can say, what do you see in the room? What do you hear in the room? What do you smell in the room? You write down from 5, 4, 3, 2, 1. Or we can keep it really simple, which is what I usually recommend in a busy clinic. It's just tell me 2 things that you see or 2 things that you're hearing right now. Let's pause. Let's both really listen because I'm feeling overwhelmed. This is chaos today, isn't it? What are 2 things you hear? 2 things you see? How about what you smell? Ground it, because we know sensory skills research shows us is the #1 way to get that frontal lobe back online so we can be trauma-informed care, meaning we care that our people are feeling heard, seen, and valued. We're also going to maybe stop and breathe together, co-regulate. Let's both take a breath. This paperwork is overwhelming me. Let's talk through it together. How do we support our systems to improve trauma-informed care processes or environment? We're going to do this by considering the lighting. Is the lighting too harsh? Not enough? We're going to be mindful of sound, and that's tough in some of our clinic settings or larger agency where there's a lot going on in a milieu setting. So trying to manage everything that we can, not having too loud of traumatizing noises like slamming doors, be mindful of the TV and what is going on around us. Ensuring we have privacy so we can step into a room on the side to have certain conversations and connect. Having a physical place for staff to walk away and take a break. We know that's essential for those 3 pillars of optimism, collaboration, and mastery. We must have patient preference of door open or closed. Well, let's talk about that. That's a trauma piece. We're going to have security personnel, right, available at some places and lots of places not in the nonprofit sector. So what does that look like? What policies and protocols do we have in place? So there's 10 key ingredients for trauma-informed care. It means we're going to lead and communicate. Guide is the word I like to use, and communicate. We're going to engage patients in planning. So what would this look like for you? What goals do you have today? How can I be of support for you, your pet, your medical care, whatever it is? We're going to train staff to talk about these things. We're going to create a safe environment. We're going to prevent secondary trauma, meaning we're not going to re-traumatize with environment, language, aggression, our tone. We're going to build informed workplace. We're going to involve patients in their treatment, setting the goals, that's self-determination. We're going to screen for trauma if it's appropriate. We're not just screening all over. We're appropriately screening. Using trauma-specific treatments and engaging in partners and communication with that's the whole collaborative. So things to consider organizationally using trauma-informed care. The training we already said, understanding to burnout happens for us. So those 3 pillars of resiliency, providing conversation and opportunity to discuss that and have mastery in our work. Making sure on our regional councils or council board, we have patient voices, those client guest voices. We're budgeting for spending with time with patients, meaning we're giving enough time in clinic. And that means sometimes we have to set limits. We're acknowledging the conflicts of the job, given patient choices and autonomy. We're considering the screeners for history. We're considering incorporating questions about safe self-regulation when triggered. What would that look like? The breathing, the sensory, and letting the patient guide. All right. Then we're being mindful to complete a trauma-informed assessment of space. There's awesome ones on SAMHSA and the TIP 57 if y'all are interested to do a walkthrough. How does it feel in this space? And honestly, you can do that more informally as well. We're going to have our leadership being supportive and committed to this ideology. We're going to hire diverse providers for those our community can see themselves in and find the lived experiences. We're going to support ourselves and our staff to be curious and change things when needed, less rigidity in systems. We're going to be creative, right? We're going to have programs that support that human-animal bond or decolonizing of our services, right? We might have some photo voices, ways for participants to lead. And that, again, the social work can bring to the side of the agency. Now I'm going to have you all set some goals. What will you do to increase your trauma-informed care within yourself? What will you do to increase trauma-informed care within your organization or leadership? Does this mean just bringing it up? Simple 3 goals here is my ask of today. If you have questions and further conversation you'd like to have, please email me. I've included that here. And also I have all my references with those different tips on how do we practice as trauma-informed providers. I'm grateful for the opportunity to talk with you today. Thank you for leaning in, and leading this vision of trauma-informed care. I see you. I appreciate y'all. Good work.